Thanks very much. I feel like Scott's already started off with some false advertising and overpromising, but I'm delighted to be here. Even though I'm a New Yorker, I feel like I have roots in the Midwest. I spent 7 very happy years in St. Louis, and whenever I come back to Chicago, I am always struck by what a gorgeous city it is and what a great place it is. So I'm delighted to be here. The emphasis of what I've been charged with today is really trying to understand the environmental component of inflammatory bowel disease, which I really think is central, but I want to put that in a broader context of too many slides, so I apologize in advance. I tried to sort of pare it down as best I could to try to just stick to the broader view, and also giving you some much more specifics of where we stand and where some of the controversies are today. So it is about 100 years since I think the sort of seminal or very first description of Crohn's disease came along. T.K. Deal in 1913 wrote that I can only regret that the etiology of the condition remains in obscurity, but I trust that ere long further consideration will clear up the difficulty. It's 100 years. I think we're beginning to clear up the difficulty, but I wouldn't say we're there yet. I think we're beginning to understand the pieces of the puzzle. It was about another 20 years or so before Crohn came along with his paper. But I think this was really the first broad description of Crohn's disease. Now, we've all seen diagrams like this. And I think it's certainly critical in saying that there are these components which collide, and those people who are unfortunate enough to have all of these overlapping, or a number of these factors overlapping, will develop inflammatory bowel disease. But I also think it's very misleading, because it suggests that there's an equivalency between all of these different factors. And I think it's sort of evolved as our capacity to understand things, in the same way that the universe expands as our capacity to look further into the universe allows us to say, well, it's not 2 billion light years, it's 10 billion light years, just because we develop better technology. So I think that the initial target of immune response is obviously critical, but I think that was just one part of the puzzle. We could then understand genetics, so that suddenly loomed large. And then we're now beginning to be able to understand the microbial component, and we really haven't understood the environmental component. So when we really look at it, I think we need to sort of calibrate what the appropriate sizes should be. And not that this is exactly how it should be, but I think that the genetic component is really smaller than we've all sort of claimed it to be, and I'll go over some of that data. And I think that the microbial component is clearly important, but I think that it maybe is a little bit overemphasized in part, particularly for perhaps ulcerative colitis. And I think, at least my view of the world, is that the environmental trigger really should be much larger. So I think we have to put this into a better context of how we're looking at these different components, particularly with regard to etiology. So I think that what's really kicking off the whole process may be environmental, in conjunction with a microbial component. Certainly there are other predisposing factors. Genetic factors are critical. So this is a picture I took. These people do not have inflammatory bowel disease. They were at Twinsburg, Ohio, and Cleveland, and I went out there to collect stool. It's sort of my idea of a good time. We were trying to look at the genetic factors. The two gentlemen in the middle, not surprisingly, are brothers, and they went to high school with the women on the end who are twins, and then the guys in the back are the sons of the woman on the right. My wife did not join me on this trip, and it was fascinating, though, just to see that you would sort of begin to feel like you're impoverished if you don't have a twin, because you begin to see the world in this sort of genetic framework of everyone has a twin there, and where is my, and these were particularly twins who were into being twins, so there were about 1,000 twin pairs out there. So it's pretty remarkable, and I think that that's happened in part in IBD, that we sort of feel like we've identified all of these genetic components, and so it's really a genetic disease. And when NOD2 came along, we were all thrilled. It's really important in understanding pathophysiology, but more genes appeared, and then more, and then it became sort of like a 1950s film where more and more things come along, and then it's up to over 160 genes, and it begins to fall apart a little bit as a genetic disease. So there were unfortunate headlines like this, and when we come down to it, it's really maybe at most 20 to 25% of the risk for IBD is explained genetically. And that's probably even overdoing it. So that even though we can categorize these different genes into important larger groups, I think that one of the components that came out of the genetic effort was really highlighting the importance of innate immunity. So that it was really, IBD has been seen traditionally as a T-cell driven disease, and there's what we sometimes refer to as the T-cell mafia that sort of kept our eyes on the T-cells, and not that T-cells are unimportant, but that it's probably a broader set of problems, and innate immunity, that initial encounter with microbes, is probably part of the fundamental defect of what happens here. So NOD2 came along, and NOD2 is fundamentally a defect. It does lots of different things, but is the ability to clear intracellular bacteria is blunted. And so that was a critical advance, because it took us away from the T cell and looked at an earlier stage in the whole initiation of the disease. And so when we look at inflammatory bowel disease, and trying to understand the genetic component, it's worth stepping back and understanding the context in our population of where NOD2 sits in, because it's become so sort of hypertrophied as important. So when we look at a healthy controlled population, and we look at the most common NOD2 variant, it's perhaps, at least in this one reference population, roughly around 13% of the Crohn's disease population, and maybe about 6% in this particular reference range in the general US population. So maybe about 18.5 million Americans. So clearly an important risk factor, but not an explanation of why someone gets the disease. And when we look at IL-23 receptor, it's perhaps similar kinds of numbers. And we look at autophagy, which came along as being perhaps the strongest association with Crohn's disease. And this is perhaps 34% of the Crohn's population. Now we're getting somewhere. It's also about 25% of the background US population. So we're talking about 77 million Americans maybe walking around with not a genetic defect, but a variant of this particular product. And it's hard then to say that this is really a genetic disease. It's an important risk factor, but I think that we shouldn't see it as, I'm going to test my patients, see if they have this genetic variant, and if they have it, well, then they're at really strong risk. Yes, it increases the risk from the background population, but only partly. And when we look at this particular study, NOD2 in the Danish population, they had genotyped 43,000 general population patients for other purposes, and they looked back at NOD2, it was about 11%. So you still have a sizable percentage of people who are at risk here for Crohn's disease. 0.4% were either compound heterozygotes or homozygotes. And they looked then at the population to see how many people had Crohn's disease. Well, in the heterozygote population, it was 2. So no increase over the background population, despite the fact that this is an important risk factor for Crohn's disease. And in the compound heterozygotes, which we think it really should be even more increased, it was 0. So not to say that it's not important, and not to say that it hasn't been critically important in understanding pathways, but it's really, I think we've lost sight of some of the more important factors, perhaps, in understanding this. So it doesn't take us away from this fundamental understanding, but it means we have to understand other elements that are contributory to the development of inflammatory bowel disease. And a lot of this relies more on Crohn's, because I think we understand the pathophysiology of Crohn's at least a little bit better. But it starts with this innate immune defect, whether it's a damage to the intestinal barrier, some increased permeability, or some defect in restitution, or delayed bacterial clearance. That's an acute inflammatory response, and I'll talk a little bit about that more shortly. When it's unresolved, there's more of a chronic inflammatory response, and then you get more of a T cell and B cell activation, and then it leads to this persistence of this cycle that needs to be broken any number of ways. And another way of looking at it is understanding it is that when there's some potential threat, some bacteria that comes along, whether it is a true pathogen or whether it is a slightly different kind of intermediate species that can cause trouble for our GI tract, particularly if we have an inherited defect, you have a variety of ways of repelling a potential invader. So you've got antimicrobial peptides in the gut, you've got various other serum and mucosal factors. If that isn't sufficient to get rid of what's coming along, then the sort of foot soldier of the immune system, the neutrophil, will come in, try to dispatch with the problem, and hopefully create a quick resolution. If that can't do it, there's a broader activation of things. The monocyte populations, macrophages and others, dendritic cells, and a whole variety of other cells get more actively involved, but still an acute inflammatory response, and hopefully gets rid of it. When that can't happen, then adaptive immunity gets much more fully involved. Now, it's not quite as linear as this, but it to some extent it is. And what we see as being a T-cell driven population of problems really probably starts on the innate immune side. And so perhaps we should be looking at that for therapeutics, but that's a different part of things. And so when we look at these diseases, the question is, why did this happen, and why is it really a disease of, say, modern times? So ulcerative colitis seems to come into a population about 40 years before Crohn's does, and that's been seen sort of repeatedly in different populations. So the first good description, perhaps 1875 in a medical textbook, perhaps a little bit before that in the population, DL 1913, and that's Burl Crohn as a young man. So these are things that popped up, the genes didn't change, so what's going on in the environment and what's happened? So when we look at trends, and you see it's certainly been increasing, it maybe this is an incidence, it's probably starting to level off, at least in Western populations, but elsewhere, as we'll talk about, it's increasing. We look at Crohn's, there's similarly been an increase, but we're probably or possibly leveling off in many of our Western populations, but perhaps in other places we are seeing a marked increase. So when we look at worldwide what's happening, there's certainly been a globalization of inflammatory bowel disease. So places which formerly IBD was rare, we've seen a whole range of, so whether it's in the Middle East, Korea, Japan, China, and India. So I've done some work in India and trying to understand the rise of inflammatory bowel disease, and so far we haven't seen anything all that striking. Everyone says, well, isn't it just westernization of diet? Well, in our about 500 patients that we looked at in India, nobody was on a Western diet. Now, it may be they're having more refined foods in the diet they're eating, but it's not as if they're suddenly going to McDonald's and taking in Big Macs and fries, and that's what's causing it. So it's going to be something a little bit more subtle, but what is it isn't clear, but it is clear that in the next decades ahead, the burden of disease is going to be shifting, so that places like India and China will probably have more inflammatory bowel disease than we have in the United States and Western Europe. So when we look at the old map of North America, Western Europe, that's really shifting so that it's much more of a global phenomenon. India isn't lit up here, it should be. And certainly Eastern Europe is much more broadly involved. Africa we just haven't heard much from, and I don't know if that represents the healthcare system or other factors. And when we look at Asian immigrants to Europe, what's curious is that the risk of ulcerative colitis goes up immediately in the generation that comes to this is in Leicestershire, England, where the risk of ulcerative colitis jumped up in terms of incidence to equivalent or greater than the background population immediately in the folks who came to England. Crohn's, there's a suggestion that it may take the next generation, or it's a slower acting process and involves other factors. And I think one of the things that is interesting in looking at this is I think that we've included risk factors as, well, this is just inflammatory bowel disease, it's one broad population, and risk factors are roughly similar between ulcerative colitis and Crohn's. But what I'm going to go through now is really looking at the different factors, and what's really curious is how distinctly separate the risk factors are, for the most part, for ulcerative colitis and Crohn's. And when we look at the environmental influences, there are some that are known, and when we think about environmental influences, clearly the microbiome is the environment that we sort of carry with us, and that's critical I'll talk about that briefly, but I'll be talking about other things as well. And there's an awful lot of things that have been looked at, many of which are speculative and are interesting and fun to think about, but are really not well pinned down as important risk factors. So first way of looking at things is iatrogenesis. What are the things that we may be doing as a medical community that may be important in provoking these diseases? So appendectomy in ulcerative colitis, I'm sure many of you are aware of this. Really, when we look at this, it's a remarkable set of data that suggests that it's strongly protective against the development of ulcerative colitis. And I think for the most part, I think the best data suggests that it reduces the risk by about 60%, particularly if it's an appendectomy before the age of 21 and for inflammatory reasons. So I think that if you have it at an older age, I just had my appendectomy about 3 weeks ago. Of course, my wife told me I had an appendicitis. I said, no way. And then about a week later, I had my CT scan and had it out. But in any event, Crohn's disease, there's a suggestion that there's an increased risk, but when we've looked at it at a broader set of databases, it really is more just that there's a bias and that it's picked up earlier, but that it's probably not a true risk factor for the development of Crohn's. But for appendectomy and UC, strongly protective for factors that we don't really understand. Oral contraceptives in Crohn's disease is perhaps, and I'd say this data is still somewhat shaky despite the broad number of studies, is perhaps a weak risk factor that's probably that there's a stronger subset of patients who have a particular reaction and may provoke Crohn's disease, less so ulcerative colitis. And that doesn't really, so again, we're beginning to see a distinction not just in smoking, but with things like oral contraceptives that doesn't come up to the a risk factor that's statistically significant. When we look at nonsteroidals, I think we're all familiar with this, and it increases flares, increases hospitalizations. The selective COX-2 inhibitors are safer, and placebo-controlled trials have suggested this. Why is this? Well, perhaps we take them in part because it reduces neutrophil function. And so again, it's a hit to the innate immune system. There are lots of things it does, so I'm doing a little bit of cherry picking by saying this, but it reduces chemotaxis, cell migration, superoxide production by some of them. And so we may be impairing the innate immune system, which is good if you've just injured your ankle, but if you have Crohn's or ulcerative colitis, that may not be what you want. Vitamin D is critical. Low levels are associated with new onset of Crohn's disease. It may be that vitamin D is critical for not just bones, but the immune interaction in the gut with bacteria, particularly with NOD2. And so that may be critical. And when we look at a broad database of the Nurses' Health Study, so following over 80,000 nurses over several decades and looking at vitamin D intake, the highest quartile had a markedly reduced risk of the development subsequently of Crohn's disease. This was not the case for ulcerative colitis. So again, a distinction between the two, that vitamin D may be critical for Crohn's disease, may not be as important for ulcerative colitis. When we look at the microbiome, we know that there's a dysbiosis of the gut microbiota in IBD, and certainly not just from knockout models, that you can sort of worsen colitis with a certain set of bacteria, but increasingly we're defining the microbiome as being a more restricted set of bacteria. Now, I'll talk briefly about the microbiome a little bit, and we don't really have a good idea of function. We're having an increasing sense of what the population is, but we don't really know what they're doing that's different in inflammatory bowel disease. And I'll suggest some things and some data that we've generated that we're submitting next week, I believe, for publication about what the microbiome might be doing in part. So when we look at the environment and microbiome, there's clearly important risk factors that are somewhat associated. So the environment may shift our microbiome that then has important influences. So our initial acquisition of Flora is through the birth canal and breastfeeding. So both that the breast around it has traditionally been more colonized with bifidobacteria. So breastfeeding, not just because there's lots of prebiotics in breast milk, but also because of just breastfeeding itself. The infant is probably picking up bifidobacteria. And a breastfed infant traditionally previously had as much as 80% of their gut flora would be different bifidobacteria species. Now that's shifted, but still there's an important difference between breastfed kids and those who are not. It shifts on weaning, and then they come closer to each other. So a C-section has been associated with early onset Crohn's disease, not consistently, and breastfeeding seems to be an important protective factor against Crohn's as well as ulcerative colitis. And there's some alteration of the flora based on other factors as well. So the hygiene hypothesis that our environment is shifted so that we're not getting exposed to other components of our environment, even such as indoor plumbing. We can't do this as well now, but when we looked at it in India, it was not that much of a risk factor, perhaps more in Crohn's and not ulcerative colitis. Uncrowded living conditions were actually a risk factor. This is shown inversely, but for Crohn's disease, one marker of sort of hygiene is whether, as a kid, you'd have your own towel, and that was an increased risk of developing Crohn's disease. So again, being cleaner, owning a pet has been shown in both directions, but most of the data suggests that the number of furry pets you have growing up, not necessarily an iguana, but really looking at more furry pets, protect against the development of Crohn's disease, but again, not ulcerative colitis. Daycare, paradoxically, you'd think, well, cleaner environment if you're getting exposed to all of these different infections, isn't that what we're talking about? But that's probably not the whole aspect of the hygiene hypothesis. There are other things, and it's other infections that may actually be injurious or risk factors. So when we come down to it, some of the microbiome is really importantly shaped by what we take in. So our very first meals, breastfeeding, are important. There's some suggestion that increased refined sugar, so it's stunning to me when there have been studies looking at what was our diet like even 200 years ago. So looking back at London dietary records, 1815, it was estimated that we took in, or those living there were taking in, about 15 pounds per capita of refined sugar. In the United States in the year 2000, what would you guess? Well, it's about 150 pounds per capita in the United States. So that it's difficult to get a good control population these days. Because what really are we're talking about our neighbors, and still we're all taking in a lot of sugar, but it's not, there tends to be, many studies show an increased risk of Crohn's with more refined sugar, but that's not consistent. Decreased complex carbs, so sort of the equivalent of prebiotics in our diet, which may enhance the growth of certain other types of bacteria, may be important. Fast food, this hasn't been replicated, but an increased risk of ulcerative colitis and Crohn's in Scandinavia. Coffee may be protective, but this also hasn't been really replicated. Unpasteurized milk may be protective. But when we really look at all of the dietary factors, meat has been suggested as important in flares, and perhaps this is through sulfur, but that hasn't been replicated. So we have lots of disparate data, and it's hard to really come down. I'd say the strongest dietary data suggests that dietary fiber may reduce the risk of Crohn's, not ulcerative colitis. And it may be also the most important factors are really the fatty acids and the type of fatty acids, so N3 versus N6 ratios may be the most important. And even though omega-3 supplementation in Crohn's didn't show a protective effect in large clinical trials, it still may be important in other ways, and it may be important in ulcerative colitis. So what are the determinants of the microbiome? And I just want to talk about this briefly because there's still a critical dietary impact. And when we look at some of these factors here, so this was looking at a whole set of species that's very interesting. So this is in terms of different diversity here. We're hanging out around here as omnivores. So herbivores have a much broader diversity because they're taking in lots of different types of compounds, and so they need to break those down and need to have different types of bacteria that can break them down. We have a much more restricted diversity in our diet, and then people with a diversity of microbiome, and with Crohn's it's even further restricted. And so diet clearly has an impact. And when we look at it, just very briefly in my minutes remaining, we used to take in, meaning 12,000 years ago, before we became farmers, a much more fiber. There's paleonutrition is an interesting branch of nutrition, suggesting we took in 100 to 150 grams of fiber a day. Our diets typically now are more like 10 to 15 grams. American Heart Association recommends 35 grams. But there was this issue of colonic salvage, that complex carbohydrates go into the colon, are broken down more by other bacteria. It's a growth factor for things like bifidobacteria that we've sort of been losing from our colon. And the colon, which we dismiss as a nutritional organ, we see it just as a reservoir, may be critically important, so that the lowland gorilla who's sitting here can obtain as much as 57% of their calories from colonic fermentation. In our diet, it's probably more like 3%. So it means that our colonic environment has dramatically changed. Now, Crohn's and ulcerative colitis didn't develop 12,000 years ago, but I think it's been a gradual, progressive change that's happened more radically in the last 100 years to provoke this. And I think the colon was developed as a nutritional organ, but it's not today, and that has important influences. So when you look at some of these rural villages, in one study in Burkina Faso, there was a radically different flora than what we have today. And so that's been one important step, but functionally what's going on, we don't fully understand. There are lots of additional factors that have been looked at: north-south gradient, iron content of the water, all sorts of things. Air pollution, we've done a little bit of work suggesting that air pollution may be a factor, and ozone may be an important factor, and something that's just coming out recently. Even things like living downwind from a dairy farm. Well, they looked at this because of mycobacteria, paratuberculosis, and looking, though, in large studies of actually vets who were exposed to paratuberculosis as opposed to those who weren't, it did not seem to be an association directly. But so many things have been looked at, but many of these things have really fallen out. So let's just talk briefly about lifestyle in the minutes remaining. Smoking we're very well aware of, and there's this interesting divergence between ulcerative colitis and Crohn's. It's protective in ulcerative colitis, protective in pouchitis, reduces the risk of PSC, where it increases the risk of Crohn's, worsens the disease course, more rapid post-op recurrence. There's a slight question of, is it more ileal disease than colonic disease, but that's not really on firm ground. Why is this? Is it, again, that these things worsen our innate immune function? It may be doing other things in ulcerative colitis, but it suppresses macrophage activity, it reduces superoxide production. You may have, again, NOD2 plus smoking may, again, worsen that hit and then bring you to a point where it's worse. Exercise is another important thing when we think about what's happened in the 20th century. Reduced exercise for some is not a risk for the development of ulcerative colitis, but and actually is a risk. I put this backwards here, but is a risk for the development of Crohn's disease. And low-intensity exercise may improve quality of life. So in the Nurses' Health Study, exercise prior to the development of Crohn's reduced the risk of developing Crohn's, and it was not an effect on ulcerative colitis. So again, an important distinction between the two. Exercise augments superoxide production, a whole host of things that improves innate immune function. Stress, when we look at that, is something that all of our patients say is critical to why they have flares. And we look back from the 30s to the 60s, this was an important, particularly ulcerative colitis was seen as a paradigm of a psychosomatic disease. And back in the 30s, this is a well-marked time relationship between emotional disturbance and symptoms. Ulcerative colitis patients couldn't cope, giving up, diarrhea substituted for real accomplishment, childish dependent personality. This is starting to push the limits, I think, of what we would say is reasonable. Degree of difference so gross as to make a control group unnecessary. And this guy here, Whitcower, is speaking about 4 patients. So it would be one thing just to leave it at that, but this went on to a variety of therapies, institutionalization because you didn't want to have contact with your family, which may be at times a good idea, but not so much to treat ulcerative colitis. Psychotherapy was done at Washington University, not so much with the belief that it really was going to work, but to dispel this notion that it was a psychosomatic disease. And in the early 60s, there was a series of 7 patients in JAMA of a lobotomy to counteract the neurotic focus, suggesting potentially a benefit. Now, fortunately, we've gotten away from that type of extreme involvement, but there are elements that are coming back. So when they looked at stress in a Danish Denmark, in a Danish registry, what is stress? This looked at a registry of all patients who had lost a child below the age of 17, and we would say that's probably about as stressful an event as you can experience. And patients who already had IBD were looked at for hospitalization. Parents without IBD were looked for the subsequent development of IBD, and there was no association for flare or the development of IBD. Not the last word on the subject, and there's some suggestions, but interestingly, in the Nurses' Health Study, recently looking at depression prior to the development of the disease was a risk factor for the development of Crohn's, but there was no increased risk for ulcerative colitis. Now, the Nurses' Health Study has its own problems, but this is very interesting, provocative data. And so when we look at these factors broadly, and we look that there's a genetic component, there's a microbial component, and the microbiome may be acting to worsen innate immunity. I won't go through that data now. And then other environmental influences, some of which we've talked on here: tobacco, nonsteroidals, decreased exercise, decreased sleep is also potentially a risk factor for Crohn's, not ulcerative colitis. We can say that there's some people may have a very strong genetic influence. Something like chronic granulomatous disease may be very powerful to development of phenotype of Crohn's in the gut, but somebody might have NOD2, which is a very weak influence. And some people may need a much broader environmental component, some people a much weaker environmental component to bring you to that threshold where there's the cascade of events that eventuate in T-cell activation after the innate immune system is sufficiently injured or impaired. So all of these factors may be acting together with the genetic component to produce this impairment that eventually leads to this set of events. We need broader high-throughput methodologies for environmental risk. People are talking about the exposome in the same way we have different omics for understanding the immune system, for genetics. So they're trying to get at some sort of totality of how do we have a microchip that can look at what we're exposed to. Well, we're exposed to about 10,000 different chemicals in a day-to-day way. So I always think about this shirt that I'm wearing. I'm not bragging about it. I think it's a nice shirt, but it goes in the dryer and it comes out pressed. It's incredible. How does it do that? Well, it does that because it is impregnated with formaldehyde. So I'm walking around encased in a carcinogen. Now, it may be irrelevant. It may be irrelevant to inflammatory bowel disease, but it's more as an example of how we're exposed to all these things that we don't really think about as environmental hazards. And I think that there are massive things that we're exposed to that are critical components of what happens in inflammatory bowel disease that we have no idea at this point, and we need to understand those better. And so there are various things that we're working on for functional screens, for environmental exposures, to understand this better with high-throughput methodologies. So when we look then broadly at environmental risk and IBD, what can we say? There's some issues that are important for acquisition of the microbiome, whether it's birth mode, breastfeeding, hygiene. There's then modification of the microbiome through diet, antibiotics, which I didn't talk about so much, and smoking. And then there's sort of conditioning of the immune response, whether it's exercise, smoking, vitamin D, medications, diet, or possibly depression. When we look at the differences between Crohn's and ulcerative colitis, I think we're having an improved understanding of the broad outlines of what happens in Crohn's disease, even though we really have to fill in the picture much better. But we're beginning to have some scaffolding, at least to understand this. Ulcerative colitis, I really don't think we have a good clue of what happens. I think that there are major factors that are yet to be discovered. And I think that there's this curious divergence between ulcerative colitis and Crohn's, not just smoking, but vitamin D, oral contraceptives, exercise, appendectomy, fiber, depression, all fits in this. So they're really very different factors that may be important in the two diseases that we need to appreciate. So ultimately, what does it come down to? What can we tell our patients? And what can they do to avoid flares? Well, I think we can say with stronger recommendations, certainly avoiding nonsteroidals, quitting smoking for either, but I think it's particularly critical for Crohn's. If someone's having a flare, I wouldn't have an ulcerative colitis patient quit at that point, but it's high on the agenda soon after. And no question of trying to adhere best to medications. Modest recommendations, I think, are maintaining vitamin D levels, important in either disease, but particularly for Crohn's disease. Exercise. I think there are common sense recommendations, which can be based in part on some of the recommendations we have from our data. Exercise, sleep, reducing stress can improve at least perceptions of really their improved clinical outcomes, even if it's not affecting the inflammatory process. Meeting with a dietitian, nutritionist, and screening for depression, I think, are all critical factors. So the sun is up. What we know likely accounts for a very low percentage of the risk of developing inflammatory bowel disease. There are significant environmental risks that remain unidentified. And I think that the less we know, the longer the explanation, so I appreciate your patience. Thanks very much.